Good. Hello, everybody. Welcome. My name is Priscilla. My pronouns are she, her, and thank you so much for joining us for our UW Medicine Office of Healthcare Equity Community Conversations. Today, we'll be discussing monkeypox, and please feel free to use the Q&A if you'd like to submit any additional questions. Our chat is also open as well. I've put in the chat the number to dial in if you'd like to call in, as well as the link to the page where this video will be uploaded afterwards. This will also be uploaded to our YouTube channel, so feel free to share this with your friends and loved ones. I'm going to pass this over to Dr. Chopra for introductions.
Thank you, Priscilla. Hello, everyone, and welcome to Community Conversations by UW Medicine. We have received so many questions about the new monkeypox or MPV virus, and today is a very important session of Community Conversations because we are going to talk about the monkeypox virus. The current monkeypox outbreak was declared a public health emergency in the US. The first US case of monkeypox was reported in May, and till August, we have nearly 9,500 confirmed cases. We are going to talk at length about the infection and what we know so far in terms of testing, prevention, and treatment. We are honored to have today Dr. Santiago Neme. Dr. Neme is Medical Director of the UW Medical Center Northwest. He is Senior Associate Medical Director, UW Medical Center, Associate Professor of Medicine in the Division of Allergy and Infectious Diseases. Welcome, Dr. Neme. And we also have Dr. Julie Dombrowski. Dr. Dombrowski is Associate Professor of Medicine. She is King K. Holmes Endowed Professor in STD and AIDS at University of Washington and Deputy Director HIV STD Program for the King County Public Health. Welcome, Dr. Dombrowski. Thank you so much for taking out the time for us today. And we have Priscilla Estrada, who is a Communications and Workforce Engagement Specialist, Office of Healthcare Equity at UW Medicine. Let's start today by talking a little bit about the virus itself. Dr. Neme, what is the monkeypox virus? Is it a new virus? Is there an animal to human transmission?
Hi, good afternoon, everyone. It's a pleasure to be with you. So monkeypox it's not a new infection. This first was discovered in the 1950s when this infection involved monkeys, therefore the name monkeypox. What we're seeing now is that the infection is affecting a new group of people, which is humans. And that's been different about this outbreak, where there's transmission across human and from human to human. So that's important. So is it a new virus? No, but what we're seeing is different dynamics in spread.
Dr. Dombrowski, how is the virus transmitted? Are there any certain populations who are at a greater risk?
Thanks. The virus is transmitted through close personal contact, usually skin-to-skin contact with somebody who has the infection or with contact with respiratory secretions. It really does require close personal contact, usually prolonged face-to-face contact, and in most cases we've seen to date, intimate contact, like in the context of sex. It can theoretically be spread through things like sharing of sheets or towels immediately after someone with the infection, but it's not clear the extent to which that is contributing. It doesn't seem to be much. So to date, in the United States and around the world, the most affected population has been gay, bisexual, and other men who have sex with men.
So, Dr. Dombrowski, is it fair to say that, and one of the questions that we got from the community was, is there any transmission sexually per se with exchange of bodily fluids, or is it just due to the prolonged skin contact through the lesions and the scabs?
Right, that's a great question. So it definitely can spread in the context of sex or intimate contact because of the rubbing and the close personal contact that occurs and exchange of bodily fluids, including saliva. We don't know yet for sure if it is transmitted through semen, for instance. It is there in the semen, but we don't know for sure if that leads to transmission. So at this point, from what we know, it's mostly that close personal contact, direct skin to skin and respiratory secretions that occurs during intimate contact or sex.
And also we are talking about prolonged skin contact. It's not, via a simple handshake. Is that what we understand?
Yes, absolutely. That's a really important point. This isn't spread through casual, brief contact. It's not spread through items or sharing a seat on the bus or trying on clothes, anything like that.
And how long is the incubation period for the virus?
It can be 5 to 21 days. Most people notice symptoms around 1 to 2 weeks after contact.
One of the things that people wanted to know is, how about contact with materials used by people, like you mentioned, towels or bed sheets or things like that? When would that become a source of transmission?
So I think for someone who knows they have monkeypox, it is reasonable to not share bed sheets and towels with a partner or other household contacts and to disinfect them in between. But again, really important that this doesn't occur from contact with casual items out in the world. And I think it's important to think about how different we would be seeing this infection in the world if that were the case. I want to invite Dr. Neme to comment on that if you have anything to add to that as well.
No, I think Dr. Dombrowski made excellent points. I think it was very clear. I think it's really important to understand that this is dynamic, that we're learning more, and that this is true as of today, and we might learn more in the future. But it makes sense to have a cautious approach, but not too fearful that will stop us. So that's what we're trying to do here, is really to provide this clear communication and information so that everyone can make their own decisions and hopefully reduce risk.
One of the other things that we really wanted to address was, can you please talk a little bit more about the aerosol transmission? Is that a possibility, and how much should people worry with regards to aerosol transmission now that masking is not that prevalent in the community?
Great question, thank you. It does not spread through the air. It does not spread through aerosol transmission. It can spread through respiratory secretions, but that is really different than things floating around in the air. And I think one thing, many of us may remember how at the beginning of COVID, people thought it didn't spread through the air, and we found out it did. But the monkeypox virus has been around for a long time and is closely related to smallpox. So we do know a lot more about this virus than we did about COVID, which was really new to the world.
Thank you very much. Dr. Neme, what are the clinical characteristics of the MPV infection or the monkeypox infection? And when is the greatest risk of transmission during the disease?
Great, thank you. So I would like to distinguish two different, in a way, presentations. There's the classic monkeypox virus infection that was described in the 60s, where it's usually a febrile illness, where you have fever and you have malaise or fatigue, and then you have these lesions all over your body or sectors of your body. What we're seeing in this outbreak, that again is affecting mostly gay and bisexual men who have sex with men, also based on our data in the US, but also the UK, what we're seeing is that it's more of a prodrome of fever and sometimes a lymph node enlargement, and then followed by lesions. But what's interesting about the lesions is that they're more mucosal. So they're more likely to rest around the mouth, the throat, the penis, the anus, vagina, etc. So areas where you have mucosa to skin transitions is where we're seeing these lesions. Unlike the classic infection, where we saw more of a general skin manifestation. So I think that's important to recognize. What do most patients tell me that they experience? They initially have this kind of fatigue and fever, and then followed sometimes by unexplained like rectal pain if they've been having anal sex, and then the lesions show up in other areas of the body. or maybe the lesions in the genital areas become more visible and prevalent and predominant. But I would ask Dr. Dombrowski to also share her experience, because she works at the King County STI clinic or sexual health clinic, and she's seen more patients than I have. So Julie, what do you think?
Yeah, I think that was a great description. I think the most common presentation is someone first has that prodrome, what we call the prodrome, of feeling sick all over, often sort of fatigued, maybe feverish, noticing lymph node swelling, and then has the rash, which can be, it kind of looks like pimples, little pustules, most classically, on different parts of the skin, but it can be in just one part or on the genitals or in the rectum, and it can look and seem a little bit more like other STDs, like herpes, for example, that can present the same way. So yes, I think what you described is what most patients are experiencing, and there's a wide range in the degree to which people feel sick and have pain versus it being a pretty mild illness.
Thank you.
And then Dr. Neme, when is the greatest risk for transmission? What was during this period of infection and of incubation?
Typically early on, like around the time you get symptoms, is when your viral load will be kind of peaking. That's traditionally what we see. The important piece of this is that you could remain contagious all the way until you've already, so basically, typically when we see infections that affect the skin, we say that once you scab, you're safe. Not for this infection. The scabs here are infectious. So what we tell patients is to really wait until the scab falls off and then you have new skin. And for that, it could take 3 to 4 weeks to happen. It could be shorter if you're receiving treatment, and we're going to talk about that. But you are contagious until everything has completely healed, meaning the scabs fall off, new skin develops, and that's when you are able to go out of isolation. Julia, also welcome your thoughts here.
No, I agree with what you said.
So there is a question here in the chat. Would monkeypox lie dormant in the system like herpes simplex virus once the initial physical symptoms have cleared up?
We don't think so. And there are studies being planned right now to look at things like viral shedding, which is when the virus is on a part of the body, but not necessarily causing lesions or symptoms. But from everything we know right now about monkeypox, it's only contagious when there are symptoms you can see and visualize, and then it goes out of your system after the healing.
Dr. Neme, you talked a little bit about isolation. Would you like to elaborate on, are there any recommendations with regards to isolation once someone is diagnosed?
Yeah, so the recommendation is to immediately, at the time you suspect you might have monkeypox, because of that, again, that fever, that prodrome, that episode of fatigue, that should make us think today we might have COVID or we might have monkeypox. Whatever it is, I need to isolate, right? And when you have the lesions, then it's important to get checked out, to get tested, but also continue to isolate. So, and you continue to isolate at home until you have new skin throughout your body. So no more lesions, no more scabs. That's the recommendation.
Thank you. Dr. Dombrowski, can you please talk about the testing available currently? Where can folks go to get tested, and what is the turnaround for the tests?
Yes, that's a great question. So right now, people can go to a number of different sites for testing, but unfortunately, it's not available everywhere. Many primary care providers are still working on getting access to the test and getting up and going. So certainly, it's worth calling your primary care provider if you have one. It is available throughout UW Medicine. It is available at the Sexual Health Clinic, the Public Health Seattle and King County Sexual Health Clinic, which is located at Harborview. So anyone who's having trouble accessing it through a primary care provider could certainly come to the Sexual Health Clinic. At the beginning of this epidemic, just a couple months ago, it was only available, the testing, through essentially CDC-run public health labs. But now it is more widely available through both commercial labs and at the UW in our own virology lab.
So can you talk a little bit about the test itself? Is it a blood test, and how long do the results, does it take to get the results?
It's a great point. Thank you. I forgot to acknowledge that. So right now, the only time that we can do testing for monkeypox is when somebody has skin lesions, because what we do is rub a Q-tip on that lesion and send it to the lab for them to look for the genetic material that's in the virus, what's called a PCR, or a polymerase chain reaction. Just looks for a piece of the virus in the lab. We don't have a blood test, and we don't have a way to test people without symptoms. So it really does involve, if you have an unusual rash, and especially if you're somebody at higher risk for having monkeypox, getting it tested at that time. And the turnaround time depends on where it's sent. For my experience here in the sexual health clinic and working mostly with the UW lab, it's around 1 to 2 days, comes back quite quickly.
So, if someone suspects that they may have it, they should reach out to their primary care doctor, who can arrange for the lab test to happen. Dr. Neme, is there a treatment available? If so, who would be a candidate for treatment, and how do they get their prescriptions?
Yeah, so there is a treatment called tecovirimat that we've been using. It's a treatment that requires an informed consent, because a lot of the data came from, again, originally the studies were in animals. So therefore, there isn't enough information or data on humans, although that's quickly changing because we are treating a large number of patients when we think about the US in general. How do you get treated? Honestly, the threshold that we have to treat someone, evaluate someone for treatment is really low. That is, we want to see every patient who has a positive test and offer treatment. Sometimes the lesions can be so predominant and classic that we can go ahead and treat folks pending a test, although that's unusual, but we've done it. But definitely the way you get treated currently, and I'm sure Dr. Dombrowski has an update on this, but UW Medicine, we've centered the treatment through a referral to the Harborview Infectious Disease Clinic. And then we send referrals across the UW Medicine system to see who has the availability to see this patient. And then we have, these are more frequently telemedicine visits, again, to avoid the contact. And there are 2 routes. There are oral, there's an oral form like by mouth, and then there's an IV for those who can't really swallow. But the vast majority are treated with oral medications. The threshold for us to start treatment is also easy to reach, because it takes that someone has a lot of pain, someone has a lot of a huge number of a high number of lesions, that someone has an immunocompromising condition like having HIV, for instance. So I would say that most patients that I've evaluated, I've offered treatment. I would say all of them actually that I've seen. But Dr. Dombrowski has seen more patients, so let's see what she has to say about this.
No, I agree the same thing. So that's important, that our community standard, and certainly our standard within UW Medicine, is really to offer treatment to most or all people with monkeypox. The CDC recommendations still do recommend it for people with more severe illness or people with immune compromise, but we have been offering it more widely. So in the sexual health clinic, we do have some medication stocked and can start treatment when we have a really high clinical suspicion, meaning we really think that's what it is when we evaluate the patient. And if not treated then, offer treatment when there's a positive test, and it involves going through the Harborview pharmacy right now for us, but it is relatively easy to get. The good news is we do not have a shortage in treatment nationally. Unlike vaccine, which we'll talk about soon, there's plenty of treatment, and we're learning more about it as we use it.
So in addition to Harborview, other pharmacies also carry this medication. Is that what we understand?
Not at this time, but we're working on working through the other UW Medicine pharmacies. It hasn't been a huge obstacle though, because the number of prescriptions that we issue a day are not so high. Because again, we're relatively at kind of a low case count, not low, but so it's manageable for now to centralize it through Harborview, but we're working on obviously getting the treatment more available. It's just, it does require that informed consent. It does require some counseling. So it's a bit complicated that way, but we're planning on spreading, on kind of distributing the drug more. I don't know, Dr. Dombroski, if you have other thoughts about it.
I think it is important to note that right now, because it is an investigational drug, as Dr. Neme said, there are only some providers who are approved to give treatment. So it's not every provider and it's not every pharmacy. Hopefully that's expanding quickly and there are more providers all of the time. But it does require a provider who has that permission essentially from the federal government to prescribe the treatment.
Dr. Dombroski, any side effects to the medicine? That's one of the questions.
Yes, every medication has side effects. So the most common side effects of this medication include a headache and nausea, which at least in my clinical experience, which is small but growing, those are usually pretty mild and manageable.
And
for me, it's for my patients too. Headache and nausea. The headache is typically manageable with Aleve, ibuprofen, etc. So it's not that significant.
How about kids? Do you see this infection in kids? And is there any treatment available for them?
Yeah, that's a great question because this comes up a lot, especially in the media. So in the entire country of the US, where we've had about, I believe, around 10,000 cases at this point, 2 have been in children. So that is less than 1/10 of 1%. So what that means, of course, in theory, kids could get it. There's nothing about being a child that would make you immune to it. But from everything we know right now, kids are not really at risk for this virus. It is not spreading in daycare centers or anything like that. So I think just really important to recognize that children are not, at least right now, at risk for this virus in any meaningful way. You asked about treatment, and absolutely the treatment can be given to children as well in a similar way to how it's given to adults.
Thank you.
I just wanted to make a quick point around that. It's as Dr. Dombroski was saying, it's really not about could children get it? Of course. Could women get it? Of course. Could heterosexual men get it? Of course. So it's not who we are. It's really what we do. It's our behavior, right? And I don't mean to imply that there's good behavior and bad behavior. It's just there's behavior, what we do, right? And I think that's important to acknowledge that currently the outbreak in the vast majority of cases affects folks who identify themselves as gay or bisexual men who have sex with other men. But it doesn't mean that if I'm a straight guy, I can't get monkeypox if I have the exposure. It's all about having that exposure, right? And that's why it's really about reducing your risk, really. No matter who you are, reduce your risk by avoiding that direct contact with people with confirmed monkeypox or people that you don't know well, right? And this is why we try to say, okay, let's just reduce those encounters for now, at least until the vaccine is expanded more. Let's try to reduce those number of casual contacts while we await a better prevention for the community. So I just wanted to distinguish that. It's not that women are immune to this naturally. No, it just depends.
Right,
I
right.
think
And
that's really important. Yes, that's very important.
do you mind if I just add on a bit to that as well?
Sure,
Please.
absolutely.
Right. So I do think it is important to draw the distinction between what can happen, which just as Dr. Neme said, anyone can get monkeypox, and what is happening and who's most affected. And right now, what we see is in the vast majority of cases, right, around 98% are in men who have sex with men. That will probably change over time, but that's what's happening right now. And sometimes this issue comes up of, is it homophobic to say that or to talk about that? And I don't think it's homophobic to acknowledge who is most impacted by this. What is homophobic is blaming and shaming people who are suffering from the virus. And that's really what we want to avoid. So it's really important for us to talk about accurate information, and that's important for getting limited resources like vaccine to the people who need it the most.
That was perfect. I completely agree. It was a really nice way to capture the issue. And again, it's I think it would be more homophobic to not be clear. If you recall, at the beginning of the AIDS epidemic, there was all this silence and lack of information to the gay community, and the HIV virus was really causing chaos throughout the gay community. But we didn't really act up in time, and we don't want to repeat the same thing. So let's call it like it is. It's really affecting gay and bisexual men, for like 99% over that in the country. So it's okay. So let's try to help folks who are at greater risk, and let's try to give them tools so then they can make their own decisions too.
That's really well said, and I think that clarifies a lot of questions that we received, and I think that the community will really appreciate this. Dr. Dombrowski, let's talk about vaccines now. That is, I think, the biggest questions, a set of questions that we've received, but also it is heartening to know that we do have the vaccine available. What are the eligibility criteria for that vaccine, and do we have it here in Seattle?
Yes, that's a great point. And as I answer it, I do want to acknowledge again this issue of how this is changing all the time. So please keep an eye on websites from Public Health Seattle King County and other sites to see who we are currently prioritizing for vaccine. So the vaccine is available. It was developed for smallpox and was in a national stockpile for that. We think it works for monkeypox. We are, again, learning about that as we go, but we have good reason to think that it works for monkeypox. And the estimate is that it may be as much as 85% effective after 2 shots. We have such a limited quantity. For example, here in King County, we would estimate there are 20,000 people who are at the highest risk, another 20,000 who probably need vaccine based on what we know right now. Since it's a 2-dose series, that's 80,000, and we've gotten 9,000 so far. So it's really limited quantity, which is why right now we're prioritizing it for people who are at the highest risk. And that is gay, bisexual, or other men who have sex with men, transgender people who have sex with men, who've either had known exposure to the virus, we could talk more about that, or who have some other risk factors. And here what I mean, again, is not to blame or shame or stigmatize, but to say these are things that we know are behaviors that can put people at greater vulnerability for the virus. And that includes things like having sex in public venues or group sex, using methamphetamine, having 10 or more sex partners in the last 3 months, or having had other sexually transmitted infections in the past year. I think that's rapidly changing, and we will probably be broadening the criteria but that's what it is right now. I really want to repeat that because that may have been way too complicated. Right now, we have vaccine. We are prioritizing it for gay and bisexual, transgender people who have sex with men and are at the highest risk for getting the virus. One really great thing that happened this week is that the FDA approved a different way of giving the virus, which is intradermal, put into the layers of the skin, rather than subcutaneous, just under the skin. And that means that from every vial of vaccine, we can get 4 or 5 doses instead of 1. So that really expanded the availability of vaccine.
So, Dr. Dombrowski, you said it's a 2-shot series. How apart how long apart do they have to be?
The way that it was studied was 4 weeks apart. And this is another important point because of our shortage in vaccine right now. We here in Seattle and King County, just like most other parts of the country, are really prioritizing getting more people their first dose rather than a smaller number of people both the first and second dose. But the way it was studied was 4 weeks.
And Dr. Dombrowski, how are we prioritizing people in terms of how do people, go about getting the vaccine? If they are hearing us today, they know that they are at higher risk. How do they go about? Where do they go to get the vaccine?
Yep, it's available at a number of different places. The key among those are HIV clinics, the sexual health clinic, other places that primarily serve LGBT populations. It is available in community events. The first one of those was last weekend in Central Seattle. There's another one this weekend in South King County. So those you can find information about online, and the sexual health clinic is available on a walk-in basis. So we give vaccines to people here who meet those criteria between 8 and 3 every day but Tuesday, which is 9:30 to 3, and people can walk in for that.
Great. And then, Dr. Dombrowski, let's talk a little bit about people who have had the smallpox vaccine. Does it offer any protection? Do they need to be re-immunized?
It offers some protection, but not enough. So also, most people who have smallpox vaccine got it a very long time ago, and the degree of protection it can offer wears off over time. So for somebody who is otherwise in a group prioritized for monkeypox vaccine, they should get it regardless of whether they had smallpox vaccine in the past.
So it does not matter how long ago they had it, but we do know that it wanes over time and that they may need to be re-immunized. Dr. Dombrowski, would it be fair to assume that in the coming, near future, that the criteria for vaccination will be expanded?
Yes. Yes.
And you do see it being expanded to, other demographics, right?
I think so. And I think that's really active discussions that people at public health are having every day and reviewing every day what we know about the cases in people who are diagnosed. And so I think that will be changing over time.
We have a question in the Q&A. If a person is exposed to someone who is symptomatic with a confirmed diagnosis of monkeypox, is there any preventive benefit to getting the vaccine and or treatment in the absence of symptoms or before symptoms present?
Yes, there's benefit. So we call that post-exposure prophylaxis, meaning prevention after you've already been exposed to the virus. It's most effective to get the vaccine within 4 days, but it's probably effective up to 2 weeks after. So anyone who knows they have had an exposure should get the vaccine. We don't do treatment for people who do not have symptoms.
Okay. Dr. Nemec, can you talk a little bit about infection prevention? How can we prevent the infection from spreading if someone is a household contact? What precautions should they take and for how long?
Excellent. So as Dr. Dombrowski was saying, if you've had a close exposure, a close direct contact with a person with confirmed monkeypox, it's really important to get evaluated to get the vaccine because you would be bumped in that criteria for now. I would say when you have monkeypox, the key thing is not so much the emphasis on the management of air like it is with COVID, with the masking and all that. It's more about really being in the same in your own space because of, you could have a monkeypox lesion and then touches some of the bedding and things like that. So we like to avoid kind of sleeping with with your partner, let's say, or having direct contact with others in that regard. So that's basically the recommendation. And again, until all of the lesions have healed and there's new skin. If you've been exposed, though, we just recommend that you get the vaccine and that you monitor your symptoms. But we're not recommending that people stay isolated for 21 days if you've been exposed, because hopefully with the vaccine and hopefully you were exposed, but just a bit briefly. Remember, this takes more prolonged, intimate, direct skin-to-skin contact. It's not something that I'm going to get by shaking someone's hand for a second, right? Although shaking hands should be discouraged because of COVID. Julie, I don't know if you want to add anything to that.
No, I agree.
Okay, one of the questions that we had, we received is, due to the length of time monkeypox can stay on surfaces, is there moderate concerns that things like trying on clothes at stores and using public transportation, I know that you guys commented on this a little bit, can be a problem? Also, should people go back to sanitizing their groceries like they were doing before?
Do you want to take that, Santiago?
Sure. Again, it seems very, very, very unlikely that you will get, right? Impossible that you would get monkeypox for being on the bus, touching. It's not the mode of transmission. You need to have you have to have a person with an active infection and then direct contact, and not only contact, but prolonged, like really close contact. The type of contact that you have when you're having sex with someone, when when you're with someone really, really close, when you're sleeping with someone, for instance. So when you're caring for someone as well. So those are the scenarios. So I'm not too concerned about monkeypox living on the desk, and then I'm going to go ahead and touch the desk, and it doesn't behave like that biologically. And even the transmission with linen and things, that's theoretical. I don't think that's a primary risk. The primary risk is really that direct touch with an infected lesion, a person who has lesions.
Sorry, I was muted. Do we know anything about the race, ethnicity data on those currently presenting with monkeypox virus?
I would defer to Dr. Dombrowski on this. I have an idea based on my small sample, but she has a bigger sample.
Yes, so looking at the current case counts and what we know, it is about, may I actually ask for 1 minute to make sure I answer this as accurately as possible?
Sure.
Do you mind, Dr. Chopper, if we go to the next question and come back? I just want to make sure I get this accurate.
Sure, absolutely. Dr. Memi, there was a question about the spread. Is the presence of lesions required for monkeypox to spread, or can it also spread when it is in the asymptomatic phase?
Yeah, so the most readily and primary transmission mode is that direct contact with the person who has lesions, right? So the lesions are infectious themselves. There is also the possibility of having droplets or respiratory secretions when we cough, or where you can actually acquire it through the mouth, the airway. But again, you have to have a very close contact with that person. And I can see that happening in the setting of kissing, the setting of just being with someone for the whole afternoon, even without having lesions on the skin. It could be that mode of transmission. But I would say the most common way, the most important thing to reduce, if we think about risk reduction, is that contact with another person with infection, or with people that we don't know. I think this is a time where, until the vaccine, I'm a gay person myself, I think it's important for our community to really try to avoid encounters that may put me at higher risk for now, until things get, more clarified, and also there's more vaccine, as Dr. Dombrowski was just mentioning.
Yep, so thank you for giving me an extra minute just to make sure I got the right information. So among cases in King County where we have race ethnicity data, just over half, 52% are white, and a full quarter identify as Hispanic or Latino or Latinx. That is, I think, changing rapidly around the country, and it does seem like there's some evidence that people of color, in particular Black and Latinx people, are disproportionately affected. So that's, I think, the key message there.
Yeah, that's really important to note. I've also had the experience where I see that it's, but I'm biased because I speak Spanish, and most of my patients are Latinos. But when you look at the data, it's overwhelmingly Hispanic. When you think about only 10% of the population here is Hispanic, but a quarter of Latinos make up, monkeypox infections. That's really concerning. So again, as we know, there are multiple barriers to care, and health equity is a constant fight. We know that for monkeypox, initially the information wasn't flowing very clearly, even in English. And now, fortunately, we're working on getting the information to the community, both through this method, but also in sessions that we're going to be doing in Spanish, and also even translating the consent form into Spanish. So as you can see, just from a language perspective, you would be disadvantaged if you don't speak English fluently. And for the African American community, it's really challenging because we know that access to care in general is worse, and we know that this is an incredibly stigmatizing diagnosis to have. So no one really wants to have this, right? These are painful lesions, fever, isolation, a crazy name, right? None of this is welcome by anyone. So I'm not surprised that we're seeing that. What we need to do is really try to say, okay, how can we elevate the playing field here so that we can give access to information and tools for the whole community, and not only for those who have internet or have a doctor or have a primary care doctor, etc. It's how do we get access for everyone to information?
Thank you. And can Dr. Dombrowski, can you please talk about pregnancy and monkeypox? What concerns do we have, of course, and can pregnant women also receive treatment and or vaccination?
Yes, this is a great question that, to be right up front, we don't have a lot of data about. So we do know that the virus can cross the placenta from the mother to the fetus, but we don't know a lot beyond that, in part because we haven't had the opportunity to study this with monkeypox, right? Just as Dr. Neme said earlier, it has popped up from time to time since the 1950s. It hasn't had this kind of human-to-human spread before. So the brief answer is that we don't know. Dr. Neme, I wonder if you know about pregnancy and treatment. I actually am not aware right offhand of data with tecovirimat and pregnancy safety.
I'm not either. I think the data are lacking, and I think it's a conversation, it's a discussion with physicians and seeing how, it's always about measuring risk and benefit and weighing that. But I think we're going to be learning more as we have more data. There was a question in the chat that I would like Dr. Dombrowski to address. Is the vaccine, the monkeypox vaccine, safe for immunocompromised patients?
Yes, absolutely. And that's a really important point, because people who are immunocompromised, we want to make sure get the vaccine and get protected, people who are at risk and have immunocompromised. So the reason that it's safe is because it is essentially an altered form of the virus that can't make copies of itself. So you can't get the infection from the vaccine. So absolutely, yes, it is safe.
Excellent. There were a couple of questions about that. I thought it was really important. And then we are treating a lot of patients who have immunocompromising conditions, and they do well with both the treatment and the vaccine. So I think it's important to highlight. Another question is whether the chickenpox vaccine prevents me from monkeypox.
Not that we know of.
Exactly, we don't know. Excellent.
Dr. Neme, I wonder if I could just briefly bring up something we haven't touched on yet. I think I can say pretty quickly, which is that we haven't seen people dying from monkeypox, right? It can be extremely painful and really uncomfortable. People can feel sick, but we have thankfully not had deaths in the United States. And so sometimes if you Google or you read about monkeypox, you'll see things about a mortality rate of 10%, which was old data in another setting. So just wanted to get that in there.
How about healthcare workers, Dr. Neme? Do you want to comment a little bit about that? Should they be receiving vaccines, or what precautions should healthcare workers take?
I think that, so currently, what I would say the risk to healthcare workers is extremely low. Also, remember that as healthcare workers, whenever we are evaluating a patient with a rash, the first thing we need to do is put on gloves. We live in an era of required masking as well. So I'm not too concerned about healthcare professionals currently in that regard. I do want to say that if someone has had a close encounter, a close contact with a person infected, that person may be someone that we would vaccinate. But given the setting of our healthcare infrastructures, I think that the risk is extremely, extremely low. Again, we're talking about most interactions when we touch, when we examine are pretty brief. And we are really required to wear gloves when we see that someone has a rash. And whenever someone has an atypical rash, that's not what we call cellulitis. We need to think about not only monkeypox, but think about chickenpox and measles and other things like that, or smallpox. So we know that we need, in the care environment, we're going to have protection. We're going to have that patient in isolation until we figure out more. So I'm less concerned about the healthcare worker for now, but I could see how potentially if the outbreaks continue to increase and it becomes more generalized, that it could be a vaccine for healthcare workers. I also could see that in the future, this vaccine could be a recommended vaccine for a gay man, right? We know that, for instance, hepatitis A vaccine is recommended for gay men in the US. It's not recommended for everyone, right? So it just depends on risk. So I can see how maybe monkeypox becomes a recommendation for the whole gay community. I don't know yet, but I welcome Dr. Dombrowski's thoughts about this.
I agree. As far as healthcare workers, thankfully, personal protective equipment works. So we are not at risk with everything we know right now. I have seen many, many patients. I myself am not vaccinated.
Excellent.
Thank you. There's another question in the Q&A. What is the time frame between exposure to monkeypox and the symptoms of monkeypox showing up on your body, like rash?
It can be 5 to 21 days, typically right around a week.
And does monkeypox virus have the potential of causing chronic healthcare issues or disabling infected persons? Or will an infected person just generally recover after the course is over?
Yeah, that's a really great question that, again, we don't know the answer to. So for all of these questions, we have to think about the fact that this just came into our awareness in May when it was happening in Europe, and sort of in June, late May and early June in the United States. So there aren't a lot of people who've had the virus for a very long time, or who've had a significant amount of time since they had the virus. So the true answer is we don't know, and we'll need to study that.
Yeah, just as a reminder, any infection can cause a post-inflammatory syndrome, right? There's multiple infections that have been involved, but it's not it's not what typically happens to the majority of folks. So if that were the case, I don't see that the entire population who got monkeypox will get this. I mean, I'm just thinking it just doesn't work like that. But you know, we've been surprised before, so I think, I mean, I agree. We need to study it and see what happens. Hopefully not.
No, you're right. I was too conservative in answering that and going right to the data, but I don't think that that happens. In the extent to which it happens, it's probably rare.
Right.
Dr. Neme, there's a question that we received is that, will you have pop-up clinics at UW for monkeypox soon, instead of having people go through the hospital? And that probably they are referring to either, sort of urgent care kind of visits or treatment visits.
Yeah, so we have currently, so I want to distinguish two things. There's vaccine and there's treatment. For vaccine, we're partnering with public health, with Dr. Dambowski and her colleagues. We're going to be participating. We're going to be participating in a pop-up clinic tomorrow as well. And then King County is doing also other pop-ups. The key limiting factor for us has been the vaccine supply, and I'm hoping that it will loosen so then we can do more of those pop-ups. Now, in terms of treatment, in terms of being evaluated, I also saw a question on the chat. If you are a healthcare professional at UW Medicine anywhere, and you see a patient with a lesion, a rash that could be consistent with monkeypox, just as you do with measles and other rashes, put the patient in the room, grab your PPE and test. We can test. It's the same test tube as the COVID test. It's the same swab. Takes a second. You test all the lesions, and then boom, you send them to the lab. And then you instruct the patient, if your suspicion is high, you can start treatment within, but only by referring to the Harborview ID clinic. And then within a day, actually, we're able to get those patients in for a telemed appointment once they've been tested and confirmed. So, or when your suspicion is high. So I feel like with the treatment piece and the testing, we have pretty good access. And remember that testing wise, UW Medicine is not the only way. Of course, we have an amazing lab, but other commercial labs are also testing. And because we're the main center that's really treating a lot of these patients, we're getting referrals from several colleagues across the city, trying to get their patient treated. So treatment and testing, evaluation, I feel like we're in pretty good shape. The vaccine piece, we're set up to go and do more pop-ups and do more outreach. We just need more supply, as Dr. Dombrowski was saying initially. But the good thing is that I'm really excited about the possibility of having 5 doses per vial as opposed to just 1. And I trust UW Medicine. And I know that if we do that, we're going to do it well. We're going to have the training, so then the injection is actually an intradermal injection and not subcutaneous, etc. So so I think there's a lot of things that are going to be coming out. So I would say stay tuned with King County Public Health, with the UW Medicine site, to see what's coming out. Also, a lot of our clinics are already vaccinating their own patients. So again, we're ready to give more vaccine. We just need more doses. Julie, I don't know if you want to add something to this.
No, I agree. I do think that we have this great tool with the intradermal vaccine, but it is important to note that takes more training. It just is you need a little bit more training and skill to give that vaccine. So that will take, I think, our whole system some time to get up and going, but we'll get there. And then the next big batch of vaccine coming to Washington from the federal stockpile will be in mid-August. So hopefully we will have some more soon. But projections around the country have said really that it's probably not going to be until October that we really have substantial numbers. So we're going to be in a tough situation for a couple of months with really needing to prioritize who gets vaccine.
And is there any role of surveillance testing? I know, Dr. Neme, you answered this question earlier in the chat, but Is there any surveillance testing going on through King County Public Health or through UW?
Yeah, unlike what happens with COVID, where you have 40% of people may have no symptoms of being infected. With these infections, you typically, when you get infected, you get fever, and then you get the lesions. I'm not aware of many people who might be carrying this without any lesions, or I don't think that's possible, although it's something that we might want to study and see whether there are people who are carrying this. But it's not an infection that lingers kind of latent, like a herpes simplex infection, right? That can just go and hide in the nerve and then come out as an outbreak. So I don't know, Julie, what were your thoughts about this? But I can't think right now that it would be high yield to test absolutely like people who are negative, because number one, I would not know what to test, because if I have no lesion, what am I testing? So I don't know, Julie, I'm sure you've thought more about this.
No, I agree with you. I think clinically there's no role for surveillance testing right now, period. It is an interesting research question that I think people will be looking at to see if you look in, say, the rectum or the throat, can you find people who are asymptomatic? We don't know, but from everything we think right now, no, and definitely no role outside of research for doing that kind of testing.
Thank you. Dr. Neme, any closing remarks, anything that you would like to touch upon, or Dr. Dabrowski, anything that you feel is important to convey to the community?
Yeah, thank you. I think that it's really important right now to get clear information. And this is why we're here. And this is why we're calling things what they are. And I think it's really important to understand that at this point, around testing and treatment, we have a really good strategy. Around vaccine, we're waiting for the supply. And when we get more supply, I think what we all need to think about how we can reduce our risk. And again, the way to reduce our risk is by limiting exposures to folks with confirmed monkeypox, or those people I don't know really well. So avoid that close direct contact for now until we have more tools. I think tool number one is to be informed, and tool number two is to see, okay, depending on what's available right now, what can I do to reduce my risk? And lastly, viruses or diseases don't have really a predilection for gay or straight or woman or men or non-binary gender or viruses don't decide who to tackle. It's just the question of where the outbreaks are now. It's really affecting the gay and bisexual men who have sex with other men. And so we really need to focus our efforts and make sure that we get those folks at risk vaccinated. And again, I was just asked, does every gay man need to be vaccinated? Not necessarily. If I'm able to reduce my risk, maybe I don't need to be vaccinated right now. But maybe when access is great, then it's something that all gay men should consider having, especially given its safety. So again, more to come, and I thank Dr. Dombrowski here for her collaboration and her leadership in this regard.
Thank you, Dr. Neme. That's very kind of you to say. I think one thing that I really appreciate so much about UW Medicine, about Harborview Medical Center, and Public Health Seattle-King County is we work really closely together. And I think that is a big part of why we've been able to have effective access to treatment, and for the people who need it the most, vaccine. We're always getting better in that regard, but I really do want people to know that vaccine is available for people at risk and treatment is available for people diagnosed. Thank you.
Thank you so much. I think this was a great and very informative session, and we got so much information, and especially helped to dispel a lot of myths that were going on in the community. Thank you so much for giving us information about testing, treatment, and risk reduction, prevention, as well as vaccination. Thank you so very much. And I hope that people will walk away with a lot of information about monkeypox. Thank you very much.
Thank you all for joining. Again, and recording of this will be put up on our website. The link is in the chat. So look for that in the next couple of days here. Please look forward to additional community conversations regarding monkeypox as well as COVID as more things come out about that. So look in your email. And again, please feel free to share this amongst your friends. I know social media posts these events as well. So please feel free to share. Hope everybody stays well and healthy, and we will see you soon. Thank you very much for joining.
Thank you so much. Bye-bye.